Toronto-Danforth NDP riding associations. Our events are meant to provide some time for us in sharing new information, new perspectives, and ultimately to clarify and encourage action that can help make a difference. Our events leading up to tonight, we're examining healthcare in Ontario. What's the prescription? We're looking at the critical problems with our healthcare system and both our panelists and your suggestions for this prescription. When we started planning this discussion last fall, there was a faint hope that healthcare might make a miraculous recovery by now. But alas, no recovery in sight. The Ontario Auditor General's report last year decried that taxpayers are paying private nursing agencies double or triple the rate that public staff nurses are paid, making the severe nursing shortage even worse. And over 1,200 hospital services like emergency departments and obstetrics units were closed last year. So I think we've all seen very crowded ERs, cluttered ERs. We know about losing physicians and nurses, and we've seen or heard of inadequate home care, understaffed nursing homes, and these are just a few concerns. We welcome hearing about your perspectives once we've heard from our gracious panelists tonight. So before we begin, I would like to ask Elise Amer from Beaches East York NDP to share a land acknowledgement.
Thank you. We acknowledge that those of us in Toronto, now Toronto, are on lands covered under Treaty 13, the Toronto Purchase and the Williams Treaties, signed by multiple Mississauga and Chippewa bands. This is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it's now home to many diverse First Nations, Inuit, and Métis peoples. While this is a largely Toronto-centric gathering, if you're attending from another part of the province or further afield, please take this time to silently make an acknowledgement of your traditional territories and Indigenous peoples. As these kinds of acknowledgements can sometimes seem hollow and performative, I'd like to encourage you to think of this acknowledgement as a commitment to being actively anti-racist, anti-colonialist, and anti-oppressive. By this, I mean that you're supporting Indigenous people politically in terms of your activism and interpersonally in their current struggles when they ask for support around pipelines, deforestations, water protection, missing and murdered Indigenous women and two-spirited people, good housing, water access on reserve, mass incarceration, Indigenous children being taken by Children's Aid. There are a very long list of concerns that we need to consider when we say land acknowledgements. Let's take a moment to consider how our land acknowledgements can fuel that active work. Thank you. Going to turn it over to Susan McMurray, who will give us an overview of the event.
Thanks, Elise. Those are definitely thoughtful words and more than thoughtful words, thoughtful ideas for us to incorporate into the work that we do. I'm here for technical reasons, just to let everyone know from a Zoom perspective how the event is going to run tonight. Except for the co-hosts and panelists, we're keeping everyone else muted just to avoid any background disturbances. And so what we're going to ask you to do is to communicate through the chat. If you have comments you want to share with other people or questions that you'd like the panelists to answer, please use the chat function. Jean is actually going to lay out how the event will proceed. Over to you, Jean.
Hey, thank you. And well, welcome everybody. It's nice to see a good number of people here on our Zoom tonight. This evening, we're going to hear from our moderator and our knowledgeable panel members about the current crisis within our healthcare system. They're going to articulate where the problems are, how it got this way, and what governments could be doing to make it better, or at least not worse, and give us ideas to go forward toward improvements as we go through the future. I'd just like to take a quick minute to say on a personal note, having been up close and personal with the system through having knee replacement surgery at Michael Garron Hospital just last November, that despite all the real problems with the system that we'll be discussing, I think we still have in Ontario some of the world's best healthcare, and it's something that we must preserve. From the initial diagnosis and presenting of options and recommendations to my finally deciding to go ahead and schedule the operation within about a 3-month period, the preparation, the last minute cold feet I was experiencing, not literal cold feet, but you know what I mean. And the actual operating day, the hospital overnight stay and the release from hospital and the follow-up physiotherapy and everything else, all the staff from the receptionist to the porters to the nurses and everything else, the operating room folks, right up to the anesthesiologists and the surgeon, everyone I encountered along this journey was caring, compassionate, and very courteous. I could see a lot of the overcrowding and stresses as I went about the hospital that we hear about, but I must say that each individual healthcare worker that I encountered made me feel that I was in good hands. And all this is just to say that we have wonderful people working at all levels in our healthcare system, and we must give them the best environment and tools to do their work. So now let me introduce our moderator for our evening, Clare Hacksel. Clare has dedicated her life to improving healthcare of others. She holds a degree from a master's degree from the University of Oxford and has over 15 years experience working in primary care, sexual and reproductive care, harm reduction and mental health, and abortion care. Her positions have spanned from clinical leadership and systems transformation to frontline work. She sits on the board of the National Abortion Federation, is a member of the Health Network of Uninsured Clients, and was named one of Canada's top 100 women for her work in women's health. And in addition to all that, Clare is currently the federal NDP candidate here in Toronto-Danforth, where she and her husband are raising their kids. So I will now turn the evening over to Clare to introduce and moderate our amazing panel. Thank you, Clare.
Thank you so much. Can folks see me or hear me rather? Great. Awesome. Thank you so much. My name's Clare. I use she, her pronouns. I'm so honored to be here and moderating this extraordinary panel. Healthcare is something that is very close to my heart. I myself am a healthcare worker, as you just heard. And like joining everyone else tonight, I'm also a patient. We've all used healthcare, sometimes more, sometimes less. But if there's anything you can count on, it's that at some point you're going to need some amount of healthcare. And when you're not a patient yourself, often we find ourselves helping loved ones navigate this complex beast we call our healthcare system. So no matter who you are, I think it's safe to say we all want the same thing: a high-performing system that is accessible, equitable, and cost-effective. But what does that really mean? I believe it means you're able to get the care you need when you need it, regardless of your income. And the care you receive will be world-class. And so that the impact of the illness or the accident that you are navigating will be as minimal as possible. Unfortunately, this is not the system we have. Make no mistake, we have extraordinarily well-trained individuals providing care within a system that oftentimes feels like is working against them while also failing patients. And there is so much we can talk about today. We could spend our time talking about primary care models and the fact that 1 in 5 Canadians does not have a primary care physician or nurse practitioner. And so what does that mean when we think about an aging population and chronic disease management? We could talk about the impact of racism in the healthcare system and how that plays out in terms of things like perinatal mortality for pregnant and BIPOC people. Or along the same lines, we could discuss the needs we need to take to really move the needle on health equity. We could focus on Indigenous health and the painfully slow implementation of the 7 Truth and Reconciliation calls to action that address healthcare. Or we could reflect on this last year that the Ford government rolled back hospital funding to see non-insured folks, and this has had a devastating impact on some of our most vulnerable community members. And while I think we will certainly touch on all of these topics today, I hope the audience will indulge me as I attempt to keep the conversation focused on privatization, the healthcare human resource crisis, and some meaningful policy changes that could impact the crisis today. However, like all things in healthcare, the conversation will be flexible, responsive, and it will unfold as it does. So to kick things off, I would like to introduce our first panelist. I will introduce panelists and then they will speak. I've got a few prepared questions, but I'm also very excited to see the questions from the over 70 people who are in the room today. So our first speaker is Natalie Mehra. Natalie is the Executive Director of the Ontario Health Coalition. Natalie has been the Executive Director for over 21 years and has built the Health Coalition into the largest and broadest public interest group on healthcare in the province, representing almost 1 million Ontarians in its network of more than 400 member organizations with more than 50 local chapters. Natalie is a recognized expert on health policy, privatization, and social movement organizing. Over to you, Natalie.
Thank you. Thank you, Claire. Thank you very much for having me today. I'm sorry, I'm a little bit sick, so please excuse my voice, and maybe someone can let me know if you're having problems hearing me. I was asked to talk about the trend, the sort of shift to privatization under the Ford government. So that's what I'll focus on, with a little bit, if there's time, on prescriptions, for change. I wanted to start by telling you about a woman whose name is Patricia Crump. She made people laugh. She was known for her wicked sense of humor. She was a grandmother, a great grandmother, a mother. She raised 5 children and survived the deaths of 2 of them and her husband to 25 years before her passing. She was a payroll administrator and she worked, according to her daughter, for 72 years. Diane Colangelo, her daughter, said her mom taught her children to be kind, to be strong, to be loving. Diane's mom, Patricia, died in Orchard Villa, a for-profit long-term care home in Pickering, on May 20th, 2020, without her family. She did not get the care that she paid for and that we all subsidized as taxpayers and residents of Ontario. Orchard Villa is a for-profit long-term care home. It's owned by a chain company that you may have heard of called Southbridge. Southbridge doesn't actually, or hadn't until just recently, provided any of the care in their own long-term care homes. They're a real estate investment company. They invested to take as much profit out as possible, and they contracted another company, Extendicare, another for-profit chain company, to run their homes. In Orchard Villa, more than 70 residents died of COVID alone, but others died of dehydration, of just failure to provide them with the basics that they needed to live, of just failure to provide the basic medical care. When they finally admitted the surviving residents from Orchard Villa into Lakeridge, the local hospital, they found that they were anorexic. They were starving. They were in kidney failure. The military had been in that home. They found that the mattresses had been put on the floor without linens. So that the residents couldn't get up and walk around, so that they were stuck on their mattresses. They had no linen, something that was found in a recent inspection report, again, in Orchard Villa. It wasn't the staff. The staff that remained there were heroes. What Lakeridge found when they finally took over the management of that home was that they were down to 20% of their staff, only 1 in 5 staff remaining. And that staff did everything they could. In absence of the family, who weren't allowed in at that point, a nurse held Patricia's hand as she died. I just want to show you a picture, if that's okay. I'm going to share my screen. This is what Patricia looked like. Is it running? Come on, there we are. And this is what Patricia looked like just a couple of weeks prior to her death. Diane says her mom was 105 pounds when she was admitted to Orchard Villa. When she died, she was 68 pounds. the question should be raised, why was Extendicare even in Ontario in the first place? Why were so many of our long-term care homes owned and operated by for-profit companies? But even worse, Extendicare had already left Florida and Texas after major lawsuits for negligence in their homes. Then in 2012, they left the state of Kentucky for the same reason. And after trying to achieve tort reform, which is a kind of legislative reform to kind of limit the legal liability of a company from lawsuits, they failed at that. And these are, think of these states, we're talking Florida, Texas, Kentucky, right-wing states, these are Republican dominated states. They weren't able to change the law enough in their favor in those states that they actually sold their holdings and left those states. Ultimately, they left the United States entirely. The US Department of Justice brought a case against them. It was the largest settlement for a nursing home chain in US history. And it was $38 million that Extendicare had to pay. And this was the statement put out by the US Department of Justice about the care that they provided. They said that they had billed Medicare and Medicaid for materially substandard nursing services that were so deficient that they were effectively worthless. That's a quote. Extendicare sold its holdings in the United States and expanded here in Ontario and in Canada. It was the Mike Harris government in the 1990s that closed almost 18,900 hospital beds. A third of the acute care hospital beds in Ontario, half of the what we call chronic care hospital beds, and then tendered 20,000 long-term care beds for the first time in Canadian history, paying for-profit companies to build long-term care homes that they would then own and operate for their own profit for 20-year licenses, which the Liberals then extended for another 2 years. So 30-year licenses, at the end of which they owned the asset. They own the land, they own the long-term care home. They can take it down and build condos if they want. They could build a retirement home if they want. And many of those licenses are coming due right now. Southbridge, which owned Orchard Villa, had the worst death rate in the pandemic of all of the for-profit chains. And the for-profits had 5 times the death rates of the publicly owned long-term care homes. There's a structural difference, and it's in staffing. There is no care without staff, period. And the conditions of work are the conditions of care in many cases. And long-term care, the for-profits had more casual staff, part-time, less full-time staff, and they paid lower wages. And they had staffing shortages that were pretty profound going into the pandemic. And then, of course, when the pandemic hit, things became much, much worse. Southbridge and Rika, the 2 worst of the for-profit chains, having had just death rates that were many times higher, 3 times higher than the average for the for-profit industry as a whole. 9 in every 100 of Southbridge's residents died from COVID alone, and that does not count all the others who died in just terrible circumstances. I'm telling you all of this, sorry, because one would expect that the kind of suffering that we saw, the 5,000 deaths of the frail elderly who lived in long-term care from COVID alone, that kind of suffering would be its own never again, that we would never see this happen again, that there would be fundamental change. And in fact, Ford promised that. He supposedly cried on TV. He said that no stone would be left unturned, that they would reinstitute the inspections that they canceled, that they would have the OPP investigate, that there would be criminal charges if warranted, that there would be fines and suspensions, and that the homes would be held accountable. At that time, 2 people who were anyway, I'll leave that. Within a couple of months, they brought in a new piece of legislation that not only didn't hold the homes accountable, they actually shielded them from lawsuits for negligence, forcing all of the families like Diane Colangelo, wiping out their lawsuits for negligence, forcing them to refile for gross negligence and then prove a higher bar for gross negligence. At the same time, they changed the legislation to make it easier for the defense. So quite the opposite of holding them accountable. Today, over Christmas, just over the winter break, sorry, the government gave an undertaking to Southbridge, sorry, for Orchard Villa to give it a new expansion of 87 beds. There's 233 beds there, expanded hugely by 87 beds, a new 30-year license, and a huge expansion to that for-profit company that was a killer company. I mean, just should never be allowed to operate in Ontario. And it is one among many. In fact, the Ford government has given the majority of licenses for new 30,000 plus new long-term care beds, whose licenses, many of them are up, to the same for-profit chain companies that had such horrific records in the pandemic and before and since. So I talk about long-term care because I think it is the most kind of visceral experience that many people in Ontario would have actually seen the consequences of for-profit, in which people would have seen the consequences of for-profit privatization of healthcare. When you turn over the provision of care to for-profit companies and their interest is in taking as much profit out as possible, then care is of course compromised, the workforce is compromised, and money is taken away from care, and the relationship becomes contorted. At every step of the way since they've been in power, the Ford government has been privatizing steadily through our health system. They have privatized COVID-19 testing. So what was public through public health and public hospitals now to private for-profit companies. And we called many of them a couple of years ago during the pandemic, and we caught them billing patients for COVID testing, $129 to $200 or more per test in the middle of a global pandemic. They privatized vaccinations to Shoppers Drug Mart mostly. Again, a public health function and a nonprofit hospital function. The Auditor General found that the pharmacies, the private pharmacies and vaccine clinics were the biggest culprits behind wasted doses. 70% of the wasted vaccine doses were in the pharmacies, 1% in public hospitals, and 4% in public health units. In fact, 2 private companies wasted 20% and 57% each of the doses that they received. They're privatizing the next entire generation of long-term care. Their plan is to build 46,000 long-term care beds to replace around 30,000 that are closing and expand the sector. And they're giving the majority of those to for-profit companies if we let them get away with it. They're privatizing now our hospital services, privatizing the core of the hospital services, surgeries and diagnostics, to for-profit hospitals and for-profit clinics. They're privatizing the staffing, as Susan talked about, in the hospitals, privatizing the nurses and health professionals and in long-term care, the PSWs, to these private for-profit staffing agencies. And they're privatizing the last public parts of home care. Again, only if we let them get away with it. And there's no question we have to fight back to stop this. We held a town hall meeting, and in every instance, of course, you can't privatize without closing down the public and nonprofit or without running it into the ground, because there's no appetite for private healthcare in Ontario or in Canada, and unless you can't access healthcare, and that is exactly what they're doing. So for example, this year, Ontario's hospitals are getting a funding increase of 0.5%, so half of 1%. Inflation from September to September, the last full year, was 5.6%. From December to December, it was 3.3%. So you can see inflation over the course of the year was much, much higher than the 0.5% that hospitals are getting. What does this mean? Well, economists call it real dollar cuts. It means they have no choice, but actually they can't even maintain the scope of their existing services. Healthcare overall is getting a 1.3% funding increase. And yet when you look at what they're giving to private for-profit clinics and services, the sky is the limit. In the last year, they gave the for-profit clinics 400% increase in their funding. They're funding Don Mills Surgical, a private for-profit hospital. There's only 2 left. The 2 surgeries in Ontario, they're banned in Ontario, have been since 1972. Governments are not supposed to expand them, but this government is. And they're paying them twice the cost per surgery for surgeries in Don Mills Surgical, that they're paying the public hospitals to do it. At every step, they have eschewed policy choices that would stabilize the staff, would bring back. There is no way through this without bringing back the recently retired staff, without dealing with the workload issues, the scheduling issues, the overwork issues that are the reason why staff have left in such huge numbers. There is no way through it, but this government is actually appealing Bill 124, their wage cap legislation that they put in place and kept in place through a global pandemic while the healthcare workforce was risking its lives to save all of us. I mean, just unbelievable. Far from doing everything they can do, they actually are what appears to be quite purposefully driving the public system into the ground and transferring resources massively from our public and nonprofit services to our private and for-profit to private and for-profit healthcare. And I'll leave it there. And maybe when we get to the discussion, we can talk about what improvements could actually be made.
Natalie, thank you so much. I know your voice is a little sore today, so we really appreciate you sharing all of that. That is like very difficult to hear. And I'm excited though to talk about solutions because that feels grim. So I'm going to turn it over now to Kingsley. Kingsley Kwok is the Vice President of the Greater Toronto Area of OPSEU and the former President Local 575 OPSEU, and is a registered respiratory therapist. Kingsley has worked as a respiratory therapist in critical care and emergency departments at Scarborough General Hospital, including as one of those frontline workers on the COVID-19 pandemic since March 2020. Kingsley?
Thank you, Claire, and thank you to the organizers, and thank you, Natalie. I've been asked to talk about home care and hospitals, and I want to start by talking about the workers who worked in home care and hospitals. As a union member who's used to dealing with management and human resources, it used to be that directors would say to me, yeah, if you don't like what's working, they can quit and I can always hire more. Well, since 4 years ago, since the pandemic, we now know, or the public now know what we always knew, and it's that government and the employer always try to keep a labor shortage, try to keep wages low, and they also ration medical and nursing education and the education spots of other hospital professionals, so that there's always competing. If anybody has watched the news, whether it is the Auditor General of Ontario's report on agency staffing, or in other situations where, because they just don't have enough employees, they are closing emergency department, whether that is hours or days at a time. Myself, I have coworkers who has gone casual or who quit their job, and not because they have reached their retirement age, not because they thought that they were getting older and they want to avoid getting infected with COVID. They quit their jobs so that they can work in places like Prince Albert, Saskatchewan, or in Alberta, where as a travel or an agency nurse or respiratory therapist, they can earn close to double and close or more than double the wage, and then come back when they finish their contract, pick up a few shifts, co-working with me, and openly telling the rest of us that, oh, we're going to go back in 2 months. That's now the situation where employers are now trying to figure out how to recruit. And what we really need is a different way to setting wages, like industry-wide negotiations. What we really need is stronger vocational training pipelines to train workers and then connect them with relevant jobs. What we really need is stronger childcare and public transit to support a healthier work-life balance so that workers are not quitting because during the lockdown, they have to stay at home and look after their children because there was no childcare open. Moving on to home care itself, like Natalie says, it was Mike Harris in the mid-1990s that opened up home care services to for bidding, setting up it as contract to be bidded by for-profit companies and some non-profit companies. And what we are now seeing through through Harris to Eves to the Liberals of 15 years and now Ford since 2018 is continuing changes in home care, but never really for the better. The bill that is up on home care now puts home care coordination in one agency and then the coordination in Ontario health teams regionally or locally, so that now they're as a patient or as a consumer, because they're of services, there is no way to find out who is accountable, what is the oversight, and for the patients who want to get care from home care companies or non-profit services, they are not getting the services they are because what is being funded is so low that if a disabled person or someone with chronic disease or chronic condition or the elderly, if they need someone in the morning and someone at night to help them to get into their bed, guess what? Some of these companies don't even provide an evening service. They actually have nobody to send to the, what some of us think is the regular hour to go to bed, like at 10 o'clock, 10:30, 11. And so a lot of patients or individuals who are in need of home care have to contract, pay extra to companies who will hopefully can provide that service. These companies, a lot of them are for-profit companies. That's a glimpse of what things is like right now with the new bill that is coming up. It's all about these for-profit private providers of home care, and we actually don't know whether there's any increase in access or increase in capacity for patients to get home care services. All we know, like Natalie said, is these companies will be able to get reimbursed by the government. And from the examples that we are seeing, the companies will get a lot of reimbursements from the government, but what the people aging at home or living at home in need of home care, they are getting not enough home care services and uneven quality, and there is no way to know whether there's any enforcement of care standards. I also want to recognize that January is Alzheimer's Awareness Month. And another piece of news that is now more and more in the at least the journalists' minds, and then hopefully and in the public's mind, is that there are a lack of alternative level of care beds and long-term care beds, and any mention of this is really about how do we deal with patients. Most of them are the elderly with dementia, and where how do we care for them? They are in need of more specialized care, and so they are not ready to be at home. And a lot of them are waiting because they got to be the moderate stage of dementia or Alzheimer's. They are sitting in the hospital and they're waiting for a placement into long-term care. But what in the continuum of someone aging is that a lot of times a lot of adults have early diagnosis of Alzheimer's, and this government or government funding to community care is also not enough. And so that where ideally someone with an early diagnosis of dementia or Alzheimer's should be able to access community services or therapy or training on how to live with dementia, or how to have family who will live with someone with early diagnosis of dementia. A lot of them are waiting for these therapies or care. They deteriorate, advance to a moderate stage or an advanced stage of dementia, and then when they get sick, they end up in hospitals and they are occupying beds. And when their other coexisting diseases are healed because they have underlying dementia, they are waiting for a placement into long-term care. And in other words, they become this alternative level of care because they've fixed the acute disease, but their underlying dementia means that they're not ready to be home now. Natalie talked a lot about privatization. I'm going to give you some examples now within the Toronto context. Hospital does many things besides surgeries and besides emergency care. A lot of us go to hospitals to get scanned or diagnostic imaging. Like an MRI, like a CT, like an ultrasound. And some of us would notice that there are also diagnostic imaging clinics that are outside of hospitals. If you recall, the McKinsey Liberals stopped the private MRI clinics. Well, more than 20 years later, we now have MRI clinics that are private. And not only are they charging or getting reimbursements from the government for OHIP that is far in excess of how a hospital get reimbursement for these imaging. We actually don't know what the quality of these scanners are. And then these private clinics are poaching medical radiation technologists from hospitals to work at double wages. So then people are saying, oh, should I stay in the hospital or should I work in some clinic in Brampton? Because that's what co-workers are telling me, that there's and then there's another MRI clinic inside St. Michael's Hospital in Unity Health Toronto, where they catered to patients that will go to this private MRI clinic, patients who will go there at night on weekends, because the public hospital is having a hard time getting workers to work nights and weekends. These are some examples of what we are against, which is the private delivery of services. So we're not talking about in the US where someone just comes up with a credit card and pays for it. They go to these private clinics, whichever one they are, and these clinics claim reimbursement from the government, from OHIP. It's just that the difference is what the government, how much the government is reimbursing them is at a far higher amount than what a hospital efficiently is able to carry out day to day. I think we already talked about the underfunding and I think of hospital care below the rate of inflation. And I think the Auditor General also has reported on the vast amounts of money being spent on agency nursing. Even for surgeries, we now know for cataract surgeries in Toronto or that other hospital that is occupying space at the Ottawa Hospital Riverside campus, and I think we now know there's another hospital that because a news organization has found out from Freedom for Information, is that all these surgeries that are being done at these private clinics, again, are also claiming reimbursement at a vast amount higher than what the hospital is. These are what we are seeing, and that's why we have we want that to change. There's really such a situation where I feel like that the government is doing this so that they want to force people to pay only to get services from a private clinic earlier than they can get services at a public hospital. And that's, it really is, because like Jean said, our hospitals are already delivering quality public care, and no clinic in Ontario or in Canada actually beat that. The only difference is that we are now being forced into is, oh, do I wait longer in the public hospital setting, or if can I actually, get a faster placement in these private clinics? And it's not always, we don't always know. Once again, I want to thank the organizers, and I look forward to questions. Thanks.
Thank you so much, Kingsley. Again, for painting such a picture. And I think you're absolutely right. I can imagine, we've all had moments, we've had people we love who are waiting for a surgery or a treatment, and you can see how it plays into your instincts, that if somebody has to wait and you had any resources, that you would try to pay your way to the front of the line. And what does that mean for health equity? What does that mean for undermining our healthcare system? Thank you so much for sharing. I'm going to put myself on mute too quickly. To our third speaker. So I'm very excited to have Franz Gélinas with us. Sorry about my accent. Your NDP MPP from Nickel Belt and official opposition critic for health, a well-respected and community leader. Franz has served as MPP for the Nickel Belt since 2007. An advocate for transparency in healthcare and government spending, she works tirelessly with communities across Ontario to improve long-term care, home care, mental health services, autism services, rural education, internet access, and road safety. France stands up to protect workers and support small businesses. Over to you, France.
Well, thank you so much. And I just saw that one of my colleagues, Peter Tappins, is now online. So I want to say hi, Peter. Looking forward to seeing you soon. So I will take you back to the basics. Medicare is a program that defines us as Canadian, as Ontarian. Under Medicare, the care we get is based on our needs, not on our ability to pay. Whether you are a newborn baby without a penny to your name, if you are sick, you will get the care you need based on your needs, not on your ability to pay. I come from the party of Tommy Douglas. This is what he brought us. He brought us Medicare. The difference is us from our good friends to the south. We get care based on our needs. But Medicare, people have to understand, has really two parts. The first is if you go to the hospital, it is free. And the second, when you see a physician, it is free. It is paid for by Medicare. But our healthcare system is way bigger than physician services and hospital services. So if you think of health promotion, it is the responsibility of the Ministry of Health to focus on health promotion to keep people healthy. I'll give you an example. If people stop smoking, have a healthy weight, eat healthy food, exercise regularly, and consume moderate amount of alcohol, 80% of all cancers disappear. Want me to repeat that? Stop smoking, exercise regularly, have a healthy weight, healthy food, and don't drink too much alcohol. 80% of all cancer disappear. Do you see our government helping people make those healthy choices? Absolutely not. Disease prevention, people who have diabetes, many end up with foot ulcer, this is the lead cause of amputations. What are we doing disease prevention wise? Very low. When you talk about primary care, where most family physicians work, this solo fee-for-service physician is a thing of the past. It is impossible to provide good quality care that way. Good quality care comes from interdisciplinary care, where your physician, nurse practitioner, nurses, dietitians, social workers, physiotherapists all work together to provide primary care. This is what every healthcare professional learns in university, learns in school, but yet still 80% of family physicians are solo fee-for-service and cannot provide the quality care of 2024. Or hospitals, I mean, we've heard about them tonight. Why is our government still fighting healthcare workers in court with Bill 124? Why are we seeing in some of the small hospitals in Northern Ontario where I live, 100% of the staff come from staffing agency? How could that be? I mean, Northern Ontario has always had some reliable staffing agency. That's not what we're talking about anymore. We're talking staffing agency who sits in the parking lot of the hospital, who hires every single one of those workers and then send them back in at 3 times the price. Our hospital in the north, all of them have deficit budget. The law is a hospital is not allowed to have a deficit budget. All of them do. Of the 141 hospitals we have in Ontario, 141 of them will have a deficit budget this year. This is unheard of. Then Kingsley and both Natalie talk quite a bit about home care and long-term care. Home care, I was there when I'm a healthcare worker. I was there when Mike Harris privatized home care. They were going to make home care better, faster, cheaper. None of that happened. What happened is that for-profit company, mainly from the States, came into Ontario, put a bid forward where if you read what they were putting forward, it looked like they were going to clone Mother Teresa. The care was going to be fantastic. None of that happened. In my neck of the wood, VON, who had provided home care for 100 years, went bankrupt. A big for-profit company came in. They cannot recruit and retain a stable workforce because they don't pay, they don't treat their employees good, they don't offer full-time jobs, none of this. They're there for one reason, to make a ton of money off the back of sick people. Our home care system fails more people than it helps every single day in Ontario. It doesn't have to be like this. And then the story that Natalie shared with us, there are thousands of stories very similar to what she shared with us of people who have no choice but be admitted into a for-profit long-term care home and do not get the care they need. About 10 years ago, I put the first bill for 4 hours of hands-on care to try to bring some accountability care-wise to the people. It'll be 2025 before Ontario looks at 4 hours of hands-on care, which is the ratio that was needed 10 years ago. The amount of sickness and frailty of the people in long-term care has changed an awful lot in the last 10 years. Those are all government choices. Those are all choices that have been made since the Mike Harris government that has helped a ton of investors make a ton of money off the back of sick people. Because once you're sick, nothing else matters. You will pay to jump the queue to get a faster MRI so that you know if you have stage 3 or stage 4 cancer. You will pay to, even if that means going into death. It shouldn't be like this. This is, remember what I told you? Medicare is a program that defines us. Medicare is based on our needs, not on our ability to pay. But what Kingsley and Natalie has said before me is that if you make the public healthcare system failed enough people, enough time, then people start to look around and say, well, maybe we should try the private system. The problem is that once you open the door to the private system, it's really hard to kick those people out of there and come back. Right now, our hospitals are getting all of 0.5, not even 1% increase. But if you are a private investor who's willing to pay to build a surgical suites, we have unused surgical suites in pretty much every part of Ontario. That the only reason it's not used, it's not because we don't have the patient's needs, it's because the hospital don't have the staff to staff them. That doesn't matter. The government, the Ford government is ready to help those people. How does that work? Well, not only do the physicians bill for the surgery, they get what is called a facility fee. Every time you go to a private clinic, the government gives that clinic a facility fee. A hospital has to do fundraising to build anything new, has to do fundraising to buy a new MRI, to buy a new PET scan or a CT scan. Not a private clinic. A private clinic put the money up front, then they sit back, and every time one of us go there, not only do the physicians pay, they get a facility fee that will pay for the expenses of their MRI, PET scan, CAT scan, whatever else, surgical suite. And then 2, 3, 4 years later, it is pure profit into the pocket of investors. Because once you're sick, nothing else matters. You will do whatever needs to be done to get your child the care they need, to get your wife, your husband, your sister, your mother, whatever, the care that they need. And they know that. Where should we start? Number 1 is primary care. Make sure that everybody in Ontario has access to primary care. primary care by not-for-profit, community-governed, interdisciplinary team. They exist in Ontario in community health center, in Indigenous primary care center, in nurse practitioner-led clinic, in not-for-profit family health teams. The models exist. The providers want to work within those models because they know this is how you provide top-notch quality care. Ask any community health center, when was the last time they got a cost of living increase? And we are talking over a decade. Are you surprised that they have a hard time recruiting and retaining the staff? They still have really, really good people who work there, who provide really good care. They do that out of the goodness of their heart because they could turn around. They have the knowledge and skills to get a job tomorrow morning that will pay way more than what they do. Why isn't the government looking at this to make sure that the 2.2 million Ontarians that don't have access to primary care gain access to primary care? It's by design. It's by design so that if enough of us are not happy with what we've got, then the idea that the for-profit will do things better, faster, cheaper. Remember Mike Harris? Home care was going to be better, faster, cheaper, becomes believable because you run the system that you have, that we have now into the ground. I know that I could go on and on, but I also see that it's 8:30, and I saw some really good questions in the chat box. So I will zip it up now, but I'm more than happy to go on with some of the questions that I've seen in the chat. Thank you very much. Merci beaucoup. Chemewech.
Thank you so much, Franz. That was fantastic. And I love your line about when you're sick, nothing else matters. I can really very much resonate personally with that feeling. You know, helping my husband navigate his health issues has been nothing matters. That becomes your singular focus. So I think we're gonna change up the screen a little bit. If you wonderful, here we go, and get all of our panelists up. And I had many questions kind of specific to folks, but now I think I just want to bring them out there, and so to whomever wants to answer. And then there's some amazing commentary going on in the thread, and if folks from the audience want to put questions there, I am going to be watching, and so we'll try to get to as many of the questions in the chat that we can. So I wanted to comment on, Natalie, your organization, the Ontario Health Coalition, released your report, Unprecedented and Worsening Ontario's Local Hospital Closures 2023. And you outlined emergency room closures across the province, and the finds are really quite shocking. Things like 868 temporary emergency room closures, 11 obstetrical unit closures. I work in obstetrics. I can't imagine just telling someone I'm sorry, you're in labor, you're going to have to go somewhere else. And a loss of over 31,000 hours of care, or the equivalent of 3.44 years. These closures are particularly devastating in rural and remote communities where there just simply isn't another hospital down the road. I was wondering if you could highlight any other key points from that report, or if, Franz, you wanted to talk about the impact on the North. I know we are very Toronto focused tonight, but I think it is important that we chat about what's happening in the rest of the province as well.
Natalie, go first and I'll go after.
Okay, thanks, Franz, and thanks, Claire. Yeah, we've been working. We have a committee. It's a small rural and local hospitals committee. It's made up of people from places like Chesley, Ontario, where their emergency department is repeatedly closed. And that part of Ontario, literally, you might drive to one emergency department, it's closed. The next one is also closed. The one after that is also closed. You know, if you go to Wingham, Durham, Chesley, Walkerton, all through that area, multiple emergency departments are closed, often with no notice, very little notice, might be the morning of. Some of them have been closed for weeks, months, at a time. But so the patient then has to try and find online if the next emerge is also closed. So if they know whether they're driving on to a hospital where that emerge is also closed. And so, I mean, we've never seen anything like this before. Never, 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 never. And the minister tried to kind of lie and cover it up and make it sound like this has happened before. This has never happened. I mean, I've done this for 27 years. Franz, I don't know how long, you're probably about the same, and I can tell you that I remember once in Seaforth, an emergency department closed because they didn't have any RNs. They only had RPNs. It closed for a period of time. Like, it was incredibly rare, almost never happened. And now we have situations like in Fort Erie and Port Colborne where they already closed the emergency departments permanently. The urgent care centers that replaced them, now they're closing them overnight and on weekends. There's no even taxi service in those communities at nighttime. There is no way for people to get from, Port Colborne to the next open hospital. And they're closing Welland as well. I mean, it's just ludicrous. And ICUs, birthing units, as you were saying, labor and delivery in Hearst, Ontario. I mean, are you kidding? That's a good 2 hours away drive from anywhere else. Kirkland Lake, the outpatient lab, there's no other lab in town. I mean, these are, and Kirkland Lake is a good hour, I'm going to say, from anywhere else as well. There's no question that these threaten people's lives. And if you were to say, what does a health system crumbling look like? Like, what is it? I mean, it would be, well, that was as of the beginning of November, that report. By the end of the year, well over 1,200 emergency department closures had happened last year alone, unprecedented numbers. So when your ICUs, your birthing units, your labor and delivery, I should make it clear what that is, your outpatient labs, when there's no other lab, I mean, when those things are closing down, your emergency departments, that is the health system crumbling. That is it's beyond crisis, it's into disaster. So what I would expect to see right now, and I'm saying this in a nonpartisan way, I cannot imagine any other government doing nothing in the face of this, and substantively nothing is what the Ford government is doing. So you would expect to see Ford in high rotation commercials out there calling back, like a wartime kind of thing, calling back the recently retired staff, smoothing a pathway, paying their licensing fees to bring them back in, promising a light at the end of the tunnel for the staff that are there, teams that they can bring in, a portal to shunt people in to where they're needed, everything possible to get boots on the ground, because the most emergency services that we have are crumbling in this province. And that doesn't count the home care that people need, that causes so much suffering that they're not getting, and long-term care. And it's not, there's no competition. I'm just using it to give context to how bad the situation is and how little is actually happening.
Thank you. Franz, did you want to?
I guess to add to what Natalie says, think of our hospital kind of like the net of last resort. Our healthcare system is really big and has all sorts of parts to it. When community mental health and addiction fails you because you need help now and you face an 18-month wait list, like in my writing, when you need home care to make sure that you eat properly, you take your medications, but they fail you, when you need other parts of the healthcare system that fails you, we end up in our hospital. Our hospitals is that net of last resort that catches all of us, that catches the parts of our system that's not working too good, we go to the hospital. But right now, our net of last resort is full of holes and jam-packed with people. Every hospital has a problem with long wait in their emergency room. We have new statistics that was just released that is just aberrant. We have overcrowding in our hospital. I mean, try to find a patient lounge or a TV room or they don't exist anymore. They have been turned into patient rooms without call bells, without bathroom, but it's a place to put a bed. And then the people who work there, we have the least number of hospital beds per 100,000 of populations of every provinces and territories. We have the least number of nurses who worked on those beds in every provinces or territories. So can you blame a nurse? She or he wants to provide good quality care. And then every night she goes home and she knows that she has failed some of her patients, people who needed her. She should have been there, but she couldn't because she's supposed to look after 5 patients, but she had been assigned 12. And then you could go work in a private surgical clinic from 9 to 5, Monday to Friday, no more evening, no more night shift, no more weekends, no more statutory holidays, no more looking after 12 patients when there's only a human being able to look for 5. I don't blame them. But then who will be there in our net of last resort? That is there 24/7 for us. That is the definition of Medicare or hospital system who looks after us. It doesn't matter if it's mental health, if it's primary care, if it's home and community care, if it's long-term care who failed you, they will be there for us, and they will only be there for us if they have the staff to do so. In my neck of the woods, Hearst does not do baby deliveries anymore. The closest hospital who does that is Timmins, which is 4 hours drive when the highway is not closed, when it's not a snowstorm, when the snowplow has gone by. That brings a lot of stress to an awful lot of people who live in Northern Ontario. So all of this, again, we know how to fix this. We are Ontario. We have one of the best healthcare system on this planet. And under this government, it is falling apart at a rate that makes me, first, I feel like crying, and then I'm angry. I'm angry when I sit in front of a health minister who knows better, who is sitting on $5.4 billion of contingency funds that could make a world of difference. Get rid of your repeal of Bill 124. Respect the people who work in our healthcare system. Show them that you care about them, and that you know that our system right now is on life support and needs this boost. None of that is happening. If you are a hospital, if you are a community health center, if you are a mental health clinic, it is almost impossible to get into the office of Sylvia Jones. But if you are a private clinic, you can get there anytime, and they will have money for you, and they will give you a long-term contract to make sure that you come into your money and that your investor makes millions of dollars off the back of sick people. I will stop because I'm getting angry.
I want to call out, it is during this government where we have one permanent closure of an emergency department in Minden Hills. And so if you can't go to Minden, you would go to Peterborough. Just to give you some geographic pinpointing, if you live on this side of Lake Ontario, there's another situation that I want to share as well, and that is because people we've been reading and hearing about the lack of primary care doctors. With the retirement of primary care doctors, we are actually now seeing elderly immigrants who came to Toronto decades ago. They require language specific healthcare professionals, and so a lot of elderly Chinese patients who are at home, their doctors have retired, and they don't graduate enough doctors who can speak Toisan, Hakka, let alone Cantonese or Mandarin, which there might still be a few. And so even that has become a situation right now.
That's so true. That's absolutely the case. We see it, I would say, in where I work in obstetrics, that folks come in and they're not always elderly. Sometimes they're just newer to Canada and like do not have English or French, and it's a real struggle trying to explain what's going on while they're having their baby. There are a couple of questions in the chat that I wanted to bring our attention to. There's one question. It's sort of a big one, but at what point are these moves that the Ford government making illegal? What role does the other levels of government, the federal government, play in intervening? And I also wonder too, along those lines, this feels like a greenbelt level scandal, and we saw what can happen when people mobilize and hold this government accountable. And I'm wondering if we see any parallels there to what we can be doing to call attention to for government, hold them accountable, and stop this erosion. To any of our panelists, whoever wants to go.
Can I go first and mouth
Please,
off, and
please,
then
Kingsley.
Natalie
Yeah, go
actually
for it.
close off and give the expertise? They are the privateers or the investors who are putting up money, building up this building in Richmond Hill, as reported by some news organization now. They are waiting for this second round of regulations to come up to allow for these licenses to be given out for private clinics. This is happening now already. So they are doing it because there's no law against it yet, because they have announced that they want, the government has announced that they want to do this. What is in the law since the Liberals was that public hospitals have these accountability agreements, which the government allocates the amount of money each hospital gets, and with this amount of money, how many surgeries, diagnostic imaging scans, or procedures each hospital will do. And as Natalie and I have been kind of trying to answer in the chat groups, it's not like there's no spare capacity. There are actually unused hospitals, spaces. There are unused operating rooms. We're not even talking about evening, after 4 o'clock, or nighttime, or weekends. There are someone else has actually looked it up through Freedom of Information. There are actually unused operating rooms during the day in GTA hospitals. Why are they not doing that? Because when the hospital get to that allocation, they actually won't get funded to do any more. So you have these investors or these physicians, these surgeons who are saying, hey, come here to get the surgery. We're going to give you premium service, and then they turn around and get these reimbursement that is, again, getting reimbursement that is far higher than what the hospital would get reimbursed for. That's what's happening, and because of that, is it illegal? We haven't found it yet, but anyway, I think some of the illegal or legal is like in the 80s when it is illegal to extra bill, but we actually have to find examples of an extra bill by these private clinics are doing. And that's why we are now talking about these clinics who are privately owned, and they're for profit, but they're privately delivering OHIP services. I'll let the expert talk more.
So to very quickly, I'll try and be quick. So what is illegal that the Ford government is doing? It's unlawful to expand private hospitals. It's not, the Private Hospitals Act banned future private hospitals, bans them from expanding. The existing private hospitals, 8 were grandfathered in when the act was brought in 1972. There are 2 left doing surgical services in Ontario. This government has expanded them. We have to do Freedom of Information requests to get their licensing agreements, their accountability agreements, licensing agreements, and try and figure out how we can prove it. I mean, they vastly increased their funding, so it goes, you know, but so we have to do that piece of work. Sorry, but that's illegal. Christine Elliott, who's the former health minister, who went, after a year after she resigned, went to lobby on behalf of a for-profit hospital. Well, they did lie in leading into the election, blatant lie. They said they sent actually, we did 20 press conferences warning that they were gonna privatize the hospitals and private clinic and bring in private clinics. They sent a ministry spokesperson out after us, and in every place, they literally said, we are not expanding the private hospitals and private clinics. At the same time, they had vastly increased their funding. Of course, we didn't find out till after the end of the fiscal year, but it's in the government's own financial documents. So they lied outright. And then, of course, 2 months after the election, they brought in, officially brought in private hospitals and clinics. That should be illegal, but it isn't. But what warrants mentioning. Christine Elliott leaving, being the minister, where she would have been making cabinet decisions on increasing funding to for-profit hospitals, and then go to lobby for the for-profit hospital. That is illegal. It contravenes the law, and we're bringing a complaint with a Democracy Watch to the Integrity Commissioner for what it's worth on that. And hopefully that should be a big issue, like the Green Belt scandal in the House. It should absolutely be. On extra billing, the private clinics do routinely extra bill patients. If you go in for cataract surgery nowadays, you're being charged often $2,000, $5,000, $7,000 for cataract surgery. People are being charged hundreds of dollars for extra eye measurement tests that are medically unnecessary, only they're manipulated into thinking they are, or they're not given a choice, or they're billed for $100 for eye drops. All those things are illegal. The manipulation is unethical, but the charging people for medically necessary services is illegal and unlawful. It violates the Canada Health Act. It violates the Commitment to the Future of Medicare Act, which is Ontario legislation, violates the OHIP Act. So we have a report coming out with patients who have been extra billed in private clinics. We did couple of them last year. We'll do another one this year, and we'll pursue it, a formal complaint to the federal government for violations of the Canada Health Act, to the provincial government for violations of the Commitment to the Future of Medicare Act. And if they do not respond by cracking down on that, we will pursue a writ of mandamus, which is a way to get the court to order the minister to uphold, order the government to uphold their own legislation. Giving for-profit long-term care licenses to homes, to chains, to companies that have terrible records, resulting in harm to their residents is illegal under the long-term Fixing Long-Term Care Homes Act, and we've taken the government to court on that. We'll be announcing that in the next week or so. Can you legislate equal funding for private and public? Well, you could, I suppose, but why would you? Because then you'd be legislating in the for-profits. And the thing is that they extra bill patients, so they'll charge OHIP, and then they'll charge patients on top, and they do it in violation of the law. We started in 2008, 2006, we phoned every private clinic in the country, caught the vast majority of them violating the Canada Health Act and extra billing patients. We've done it 4 times since. Every time we've caught the vast majority of them doing it. So kind of like the long-term care homes, there are laws, but they don't follow them. And they're so close to governments and they're so inside that the governments don't uphold the law to them, you know, and they win deregulation all the time. It's just better not to have them in at all. And finally, I'll just say, you could absolutely legislate out the for-profit staffing agencies. You could require hospitals not to use them. The Liberals actually did a little bit of that when they first got in. By the way, the Liberals didn't stop the for-profit MRI clinics. They promised to, but they didn't. But they did actually limit the use of agency staff, both in long-term care and in hospitals, and that could absolutely be done. And the Ford government during the pandemic brought in a price gouging law, and they did a whole PR thing about it. It was after the bread scandal at, the Westin, what do you call it? The Westin chain, Loblaws superstore chain, whatever. Anyway, or was it toilet paper? Anyway, whatever pricing scandal at the time. And they said that they would go after price gougers, and they never did. It was all PR. utter nonsense, but they did pass the law. And so I think we should demand that they go after these staffing agencies that are clearly price gouging. Bread. Lizzie says it's bread.
What I would add after Natalie is that by the way, I did table a bill to limit the use of staffing agency. It is there. They could act upon it, like we could pass this law in 4 days and it would be done. Would make a huge difference for many hospitals who are facing severe financial hardship because of it. When it comes to extra billing, it happens all the time. I bring those cases to the minister, and she says, "Oh, they can phone this number," which nobody knows. Which, if you are really good on the internet, within an hour search, you will be able to identify that number where you can put in a complaint. And once you put in a complaint, and yes, this ophthalmologist charge you an extra $400 for a test that was covered by OHIP. He was not allowed to do this. You get your money back. But the 600 other patients who were charged $400 for don't. It's like they have nothing to lose. There is, they can overcharge. Oftentimes, like, they will put barriers to access, or you need that test, but that test is covered by OHIP. But in order to get that test, we would like you to talk to our dietitians first. It'll be $200 to talk to the dietitian. You need to talk to a dietitian? Absolutely not. But in that private clinic, in order to get that test, you have to talk to the nutritionist, dietitians, whatever, and it's $200. And then once you've talked to her for no reason whatsoever, you get the test that is covered by OHIP. There is all sorts of that. The Auditor General did a very good report where she showed how it was happening. I brought that to the Minister of Health on different committees, and it's a joke. As I said, the person who finally finds out where to put in a complaint will get her money back, and nothing happens to that physician, nothing happens to that private clinic. They just keep on doing it the way they've always done it for the 600 other patients. It's anyway, awful.
Thank you for sharing that. I wanted to add that I think there's a piece here too, that unfortunately this story of price gouging and made up prices is something that non-insured people in Ontario and Canada have been living with. There, we know that there is at least 500,000 folks, migrant workers, people who have come here to be domestic workers, people who are driving Ubers and delivering food, and international students who don't have access to healthcare, and they are facing similar stories of when but they're actually arriving in our public hospitals needing help, and if they're not connected to a community health center, being charged exorbitant funds. And it's immoral to be, basically the hospitals are so underfunded. They're gouging on non-insured people, and they're suffering as a result. So I just wanted to make sure that piece was there shared as well. Because we cannot forget that there's so many people in this province who don't have access, who are making Ontario their home. They are contributing to our province, to our city, to our country, and they do not have access to our system. We just have a few tiny moments left in this panel. Maybe I can turn to each of you for just like a rapid fire. What is the one sort of action, the one thing that folks to walk away from this evening with, that they can either do, they can talk about, they can promote, from your perspective? I'll start with, why don't we go in opposite order from how we started? So why don't we start with you, France?
So in 1 minute or less?
1 minute.
1 minute or less. Medicare is a program that defines us as Canadian, as Ontarian. Care is based on needs, not on ability to pay. Care is delivered by publicly funded, publicly delivered care. Once the for-profit comes into the picture, everything changes. Everything changes for the worse. Our publicly delivered healthcare system right now is having a tough time, but advocate to strengthen what we have. Advocate to strengthen care based on needs, not on ability to pay. It has defined us. It has to continue to define us. This is how we will make sure that our kids and grandkids continue to be proud to be Canadian and proud to be Ontarian. It is that important to us. It defines us. Don't let a conservative government driven by making money off the back of sick people for rich investor lose track of how important that is. It defines us. It is worth advocating for. It is worth keeping.
Thank you. I'll ask you, Kingsley.
Know that with Doug Ford and us, we as voters, this is about our choice, making our choice. If some candidate come in an election, knocks on your door, rings the bell, say, how are we going to get more doctors, more nurses, more lab technologists, technicians, midwives, and other healthcare professionals into the system? How do we get more primary care doctors into the system? Right now, this government is allowing private delivery of OHIP reimbursed services. Our system is good. We are getting the care that we are getting. This is a choice. And when the next election comes, we have to stay strong with our choice.
Thank you, Kingsley. And Natalie.
So the polls, so I was reading, some people were, thank you for the info, but I'm depressed. I get it. But the polls are showing that there's across Canada, the majority of people oppose privatization of healthcare for the values, the very values that Franz so eloquently laid out every time she spoke tonight. Thank you, Franz, for that. It grounds us. But in Ontario, the opposition to privatization is much higher than even the rest of the country. And that's because of us. That's because of the relentless, reports and media exposés and all the commentary and all the social media, all the doctors that we've taught to support public Medicare over the years, frankly, and all the other clinical staff, and the strength of the opposition here and the strength of the health coalition here and the social movements and so on. I mean, that's because of us. And it's statistically much higher, the opposition to privatization. Like, what is Doug Ford's biggest weakness? Well, we still have elections. They have to get elected, and the people oppose privatization. So we have to do the maths job of communicating with the public, out communicating Doug Ford, who is a great liar. I hate to say, I mean, he is. So, and sue me, I could defend this. That's the truth. They lie and they misrepresent, and they are not honest about their intentions. And so what we need to do, this is how you can help concretely. We need to find patients who've been extra billed. We have several dozen. Some of them won't speak publicly. If anyone has been extra billed in a private clinic or manipulatively upsold, we need you, because we need people who can speak publicly, but also the people who want to remain confidential. We're gathering the stories for this mass complaint. That's critical. We need to reach the public. Last year, we got out just over 1 million leaflets, door to door, person to person, at tables. We held a mass referendum. We had more than 400,000 people vote. This year, this spring, the goal is to get out 2 million leaflets, person to person, door to door, about what the Ford government is doing to our healthcare. This kind of information, but succinctly, we need to educate, organize, and then people need to see visible resistance. That's how we win. So we want to get out 2 million leaflets that will lead to a giant protest in May at the legislature. You can help with that. I put the Greater Toronto Health Coalition email in the chat here if you want to join in. So much fun, so good for us to go door to door, and also very fun. And we'll have tables out on every busy street corner we can, and just do mass outreach, and then show people that there's visible opposition and give them a way that they can join in. And that way we can build, and there's what, 14.5 million people in Ontario. Reaching 2 million direct person-to-person contact is amazingly powerful. It is what swings things. It is what keeps that public opinion and shifts it and makes it stronger and makes it more formidable, to the Ford government. And that, for that, all of us matter. So thank you.
Thank you so much, Natalie. And thank you to our extraordinary panelists. It is 9:02. Taking the time to be here for this important conversation. Thank you so much to the NDP riding associations in Etobicoke-Lakeshore, Beaches, East York, and of course, Toronto-Danforth for putting on this evening. And thank you to all of you, all 80 plus folks who came in today. Thank you so much. Good care can only come when we listen to each other. I wish you all a very wonderful evening.
Thank you, everybody. Have a good evening.
Thank you so much. Good night.
Good night, everyone.